right, I see a couple of people still connecting, so I'm just going to give it a moment and then we'll get started. Awesome. It looks like we are all connected. Good morning and afternoon, depending on where you are joining us from. My name is Boatima Intiri Reed, and I am excited to be able to introduce you to this morning's, or this afternoon, sorry, depending on where you're at, training, the Hepatitis C Navigation Online Training. So I'm the Director of Hepatitis at NASDAD and have been excited to have been working in collaboration with NY City Health in order to bring you this training to get today. This is the companion training to the Community Navigation Training and Toolkit launch that took place in September of this year. So today we're excited to share some guidance with you that's specifically designed for hepatitis C or broadly hepatitis navigators and their supervisors. The work that will be shared with you today is a culmination of countless hours of work from New York City and also with support from NASDAD's hepatitis team. Today, you're going to hear specifically from Diana Diaz-Munoz, as well as Marie Bresnahan, who will introduce themselves in just a short moment. But I additionally want to make sure to acknowledge the following folks for their substantial contributions to this training and who are working behind the scenes during this training as well. So you'll be hearing from them as well. The first person is Neera Johnson, who is the Director of Capacity Building and Viral Hepatitis at the New York City Department of Health or Health Department, and also Jasmine West from my team, who is a Senior Associate on the Hepatitis team at NASDAD. So before we jump into the training, and I know everyone's anxious to do so, I just wanted to go over a few quick ground rules. The first one being, please be sure to mute your lines. I know at this point we've done enough Zoom and GoToMeetings and other virtual meetings to know that, but it's always safe to say. And also, if you are calling in, we ask that you refrain from putting us on hold because we are recording this and this will be put up. So we don't want to have any interruptions to the training. Also, as I just stated, this presentation is being recorded and will be made available shortly after the training, and including to folks who are not registered for the training so we can get this out to a broad audience. If you have questions during the presentation, we encourage you to type them into the chat. And the speakers will try to address them during the training. And then finally, at the conclusion of the training, there will be a brief evaluation, which is really critical to us making sure that we are meeting your needs and providing these trainings. So we'll provide the link in the chat, and we ask that everyone be sure to complete it. If you have to jump off the line a little bit early, perfectly fine. But we'll just ask that you reach out to a member of our team so that we can make sure to have you complete the evaluation. And so without further ado, I'll pass things off to Marie and Diana.
Thank you so much, Boatima. Really happy to be here today. My name is Marie Bresnahan. My pronouns are she and her. And I am at the New York City Department of Health and Mental Hygiene, or the New York City Department of Health, as the Director of Training, Policy, and Administration in the Viral Hepatitis Program. And my colleague, Diana, will introduce herself.
Hi, everyone. I'm Diana Diaz-Munoz, and I work with Marie in the New York City Health Department as the Hepatitis C Community Navigation Program Manager.
Great. So thank you, Diana. And with that, we're going to get right into this training today. And we're going to start by just asking a quick poll question. So for this poll, it's very simple. The question is, what is your role? So I think Jasmine's going to pull that up for us, and then you have a choice of options there. If you can let us know, are you a navigator or caseworker? Are you a supervisor, a program director, or other? So you'll just have a few seconds here to type that into the poll question. We're interested in finding out kind of who's on the call with us today.
Results are still coming in, so let's give it a few more seconds, Marie.
Great.
And for those that checked other, if you want to include that in the chat box, I think we'll wrap it up in about 10 seconds. All right, I'm going to end the poll and share those results.
Okay, thank you so much, Jasmine. Excellent. It looks like we have a good proportion of navigators and caseworkers on this call at 41%. We have a smaller percentage of supervisors and a smaller percentage of program directors. Dana or Nira, would you like to read a few of the responses that are in the chat of the other, so we can get a sense of who's on the call today?
Yes. So we see some peer navigators, registered nurses working in harm reduction settings. There are senior epidemiologists as well, many harm reduction specialists, and community disease investigators. So we have a really good group today.
Great, thank you. Excellent. Well, I hope some of you may have been able to join the previous webinar where Nira and Deanna went through all the resources that are in the toolkit. You'll hear about some of them today as well. And I just think this is an exciting opportunity for us to talk more about actually how to use the toolkit and how we can best do our work with this population. So I know Jasmine is still letting some people into the room, but we're going to continue. So I'll close that poll. And I have just listed here the goals for today's training. What our plan is to hopefully increase skills in providing hepatitis C health promotion to people at risk for or living with hepatitis C, and to increase your ability to navigate clients through Hep C testing, care, treatment, and prevention, as well as to identify hepatitis C navigation resources that I think will be very helpful to you in your work. And so to get through those objectives, the outline is very simple. We are going to first look at what are the health promotion messages. And then I'm going to turn it over to Deanna, who is going to work with you on the hepatitis C patient navigation steps and resources. We'll have a brief wrap up and time for questions at the end, as well as an evaluation that we'll ask everybody to do. So just to think for a minute about why we're here. I mean, certainly during the opioid epidemic, we've seen some significant increases in Hep C infections. I feel if you look at the news, you hear a lot about the opioid epidemic. You aren't really reading as much about the tremendous increase in hepatitis C infections. In this data we have shown here, from 2011 to 2016, we saw a sharp increase in the annual incidence of new hepatitis C infections, and I believe that trajectory has continued to our present day. And when we look at the hepatitis C care cascade in the United States, some of you might be familiar with this, but we know that there are more than 2.5 million people infected with hepatitis C. And you can see as this graph moves from left to right that really only half or about half of those are even diagnosed. Even less of those people who are infected and diagnosed, even knowing that they have Hep C or not, even less of those people are treated and less of those are cured. And then you see the gray bars on this graph show that we're really not in line to meet the World Health Organization's goals by 2030 to eliminate hepatitis C. We have certainly a ways to go. And this graph is for people with Hep C overall, but we know that Hep C diagnosis and treatment rates are even lower in people who use drugs. So I just want to ask and get you guys involved right from the beginning here. The question is, what do you think are the barriers to testing and treatment? So if you can type into the chat box, let us know, why is it that less than half the people with hepatitis C are diagnosed and even fewer of those are in treatment? So you have just a minute to type into the chat.
Some responses coming in include stigma, provider stigma, lack of insurance, lack of knowledge, transportation issues, insufficient health insurance coverage.
Mhm.
You're all on fire today. Definitely some information around trauma or lacking, trauma-informed care services. Lack of federal leadership and funding,
Mhm.
lack of phone or a way to communicate, providers not knowing much about treatment. I'm assuming people unwilling to see a provider,
Great.
not
Thank you.
comfortable to be in a four-wall clinic.
Yes. Absolutely. Sounds like this group is very familiar with this population and so many of the issues involved. So we heard a lot of what is now on the screen related to, I think, insurance and cost, but there are other issues maybe we didn't hear yet specific to homelessness and incarceration, as well as this issue with Hep C, which is different than an HIV test or some other tests where you need not only the antibody test, but also the confirmatory test. And then I think we did hear some of the issues related to stigma, distrust of the medical system or of providers. And we have some quotes from patients that we have surveyed and providers that we have surveyed. And we heard that from people, there's just a lack of understanding or interest in serving people who use drugs. So many health providers are not interested in treating people who use drugs. They're afraid this is a population that won't follow treatment protocols, won't come back when they're asked to come back for care, won't be engaged in their care in the way the providers hope them to be. There's also issues about this, as I mentioned, antibody testing. And many people get that antibody test. Not everybody gets a confirmation test. We know that testing for Hep C involves a two-step process. Other issues include the cost of labs and office visits and copays for people with limited insurance coverage, limited income, and many other priority needs in their lives. In addition, in many states across this country, there remain restrictions that not anybody can treat Hep C, that for a long time, Hep C was only treated in the realm of a gastroenterologist or a hepatologist or a specialist. Now, more and more, we see Hep C treatment moving into primary care clinics and to community health centers, which is critical, but that is not happening in all parts of the United States. So thank you for contributing to the chat on that and for helping us bring forth some of these important issues. So I'm going to move now into some of the key health promotion messages. And I know that there are many Hep C champions on this call, and I have a feeling there are some real experts who have joined us today. So many of us do know the basics, but how do we explain these concepts to those that need it most? And what is our skill level in terms of translating this information to clients? And what is the best way to deliver these health promotion messages? So as I go through some of this information, I hope you can hold those questions in mind as we think about how to get these key messages across. So you'll see on the bottom left, there's a little note about this pocket card. These are the key health promotion messages that are necessary for Hep C. And again, very basic to some of you, but so important that they're really understood by the population that we're working with. So as we know, hepatitis C or Hep C can lead to liver disease and cancer. Hep C is a blood-borne infection spread through blood-to-blood contact. The main way that people get infected with Hep C is by sharing drug use equipment through injecting, smoking, or snorting drugs, or by having unprotected sex. And syringe exchange and harm reduction can protect you from Hep C. As I think many of you know, we're going to go into each of these a little bit more. And getting tested to know if you have Hep C requires first the antibody test and then a confirmatory test. And the big news for anyone who's been in this work for a long time, it's just never ceases to amaze me how exciting it is. This is the only viral infection that can be cured. It is not a long-term chronic disease like HIV or like many other issues. Hep C can be cured, and the treatments for it are now shorter and more effective than ever before. And the side effects not only are less severe, they're really minimal for most people. But still, someone who's cured of Hep C can get reinfected. And it is important that the community we work with understands that and understands how to protect themselves from exposure to blood and Hep C on an ongoing way. And of course, with any liver disease, Hep C being the most common liver disease, that avoiding alcohol is important. Alcohol speeds up liver damage, and even after you've been cured, you may have had significant damage to your liver. So being very aware of how alcohol and other drugs affect your liver health is critical. So let's move in to some of this by asking a question. I want to ask a question of all of you. So based on these key messages, hopefully many of them you're already implementing in your work, but what would you add to your conversations with patients or clients? Would you emphasize some of these key messages more? Is there something that you would add? So again, if you can write into the chat and let us know, what would you add to these key messages in talking to your clients, your patients, or consumers? And I know Deanna's reading the chat, so I'll give you a moment to type your answers, and I think she'll share those with us.
So the first comment is to emphasize the minimal side effects associated with treatment. Talk about harm reduction use. Emphasize exactly how hepatitis C can be transmitted, especially around injection, smoking, or snorting, and minimal side effects. Once you start on treatment, you'll probably start to feel a lot better within a month. That's really a good motivation right there. Since Hep C is now, Since Hep C is now a curable infection, there is a good reason to be tested. Knowledge is power.
Excellent.
And someone adding, definitely talking about reinfection. And there is a very passionate message, and I just want always assure them that there is a treatment. So definitely, and I think all of you here, and we hope that today you will become hepatitis C cure ambassadors.
Great. Thank you so much, Deanna. So not only is there a treatment, there's a cure, and getting that message out is so important. Thank you all for writing in the chat. Keep writing as we move forward. That would be great. So I'm just going to focus for a few minutes on Hep C transmission. Of course, we've already said that the most common way people get infected with Hep C is by sharing injection or intranasal drug use supplies. It is the most common way Hep C is transmitted in the United States and around the world. So many people are infected with Hep C and don't even know it. And this issue I just want to think about for a moment with Hep C and drug use is what's different about the message, the health prevention message for Hep C than is for HIV. In HIV, for many years, the CDC has asked us to educate injection drug users because injection drug use can put you at risk for HIV. And the CDC instructs us that the key message with Hep C is similar but different and not so easy to get across. With hepatitis C, the real health prevention message is if you've ever injected drugs, even once a long time ago, or if you've ever shared a needle, even once a long time ago. So I mentioned that Hep C infection causes liver disease that can often be very silent. And drug use for someone that used drugs in the 1960s, in the 1970s, when in the age of sex, drugs, and rock and roll, that person may have gone on to never use or never share a needle again, never use that kind of drug again, may have gone on to not be a drug user at all, but they may have been infected with Hep C this whole time. So of course, that's why we've targeted so many messages to baby boomers about hepatitis C. But now we live among this opioid epidemic. So there are many younger injectors getting infected with hepatitis C. So it's a critical issue to look at and talk to people about and find creative ways of finding to talk to people so that we can understand their risk. Of course, there are other things that put people at risk for Hep C. Unsterile piercing and tattooing. Now, there aren't huge studies about the massive amounts of people who've gotten infected with Hep C this way. There really are not. But of course, a needle that is shared and put into your skin and then put into my skin. I mean, this is most likely going to happen maybe with a jailhouse tattoo or a gangland tattooing. Certainly not a licensed tattoo parlor that is using all the safety protocols as deemed by their local health department and is using new needles every time. But unsafe tattooing can spread Hep C. Again, not very common, but sharing personal items such as razors and toothbrushes. Of course, working with homeless populations or incarcerated populations. If you're sharing a toothbrush or a razor and there's blood on it from someone else and then you use that as well, that could be a way to transmit Hep C. And although the blood supply now is very safe and is screened for Hep C, prior to 1992, Americans that got blood transfusions could have been at risk for hepatitis C. And anyone over a certain age on this call might even remember this is what used to be called hepatitis non-A, non-B. They didn't even know what it was in the late 1980s. They knew it was not hepatitis A. They knew it was not hepatitis B. And it was in the blood supply. But since 1992 and in the early 90s, when they were able to identify this as a new virus called hepatitis C, they were also able to screen the blood supply, so the blood supply is now safe. But people did get blood transfusions in the past, which put them at risk for hepatitis C. As well, medical procedures, not so much in the United States, but in certain parts of the world that could involve needles, acupuncture, other kinds of treatments where there's a high burden of Hep C and there's just not the supply, the medical supplies to go around, so that needles may have been reused to vaccinate people. Needles may be reused for other kinds of treatments that could have infected people with hepatitis C. And also during childbirth, a mother can transmit Hep C to her child during childbirth, and as well during sex. So this is not commonly transmitted sexually. Hepatitis B is much more easy to transmit sexually, but hepatitis C, where there is a presence of blood, this could be anal sex, this could be vaginal sex during a woman's, when she's menstruating. It could be any kind of sex where there is a presence of blood that can get into someone's bloodstream, can spread Hep C. So there's a lot of subtle messaging in here that we have to get good at as health promoters on this issue, as health educators on this issue. I mean, we certainly can't have people scared about everything on this slide, but they have to understand the relative risk of some of these issues and certainly the very high risk of other issues such as injection drug use or intranasal drug use. Now, throughout any of this, we have one of our colleagues and experts in the chat room answering questions, and other people monitoring the chat. So please ask questions in the chat box as we're moving forward through this information. So again, the issue with Hep C and injection drug use. Now, of course, there's a big issue with the needle. Many needles have a hollow bore, and even if you can't see blood in that syringe, it might be hiding in the bore of that needle. So if that needle is left lying around and someone else uses it, but when people use drugs and shoot drugs, blood can splatter onto the tourniquet. They use a spoon or other kind of cooker that they might share the cooker and the cotton. They might be sharing the same rinse water. And then as you put a needle into that rinse water, you can be putting blood in there. When someone else uses that same rinse water, that can infect them with hepatitis C. So there's also many subtle and complicated messages really that have to be given to injection drug users about how to inject safely, and making sure they're very much aware of where to get clean syringes, because of course the best message is a new syringe every time, not sharing needles. But if people are going to share needles, they have to be aware of this whole setup, which can infect them with Hep C. And they have to be aware of how to do it safely. So in terms of screening people for Hep C, we're very excited about the newest guidelines from the Centers for Disease Control, which are for universal Hep C testing. So some years ago, a guideline came out which recommended that physicians test every boomer at least once, every baby boomer at least once in their lifetime. And then test other people who are at risk. Well, those guidelines have now changed, and they're much more universal and much more broad. Now the guidelines are that all adults age 18 and older should be screened for hepatitis C at least once in their lifetime, not just baby boomers, all adults 18 and over. And all pregnant persons during each pregnancy, not screened in just one pregnancy, but each time they get pregnant. And then of course, people who are at most high risk, people who use drugs, should be tested or screened every year. So helping us get this message out, and as more and more physicians and health systems start to implement their universal screening, hopefully we're going to find more of the people with Hep C who have not been treated as of yet. And then what does this testing look like? Well, testing for Hep C, as I've mentioned, requires 2 steps. There is an antibody test, which shows if a person was ever infected, and there's a confirmatory test. So the confirmatory test, an RNA test, also called a PCR test, is critical so that somebody knows if they're currently infected and needs treatment. Now we have a picture on the screen of a rapid test. So the antibody test can be done with the blood draw, or there's a finger prick test, this rapid test. If you do a finger prick on someone, just get a drop or 2 of blood, insert this rapid test into the tube with their blood, then you'll get their results, their antibody results, in 20 minutes. However, if they're antibody positive, as we'll see, that's not enough information to know if they should be treated. So let's talk a little bit more about those test results. So if someone is antibody negative, as you'll see on the right side here, that means they were never infected. They're not currently infected, and they weren't infected previously. Unless, of course, they had a recent exposure and you're testing them in that window period. So this is similar to HIV. We know that if someone tests negative, they should probably be tested if they're having recent risk within 3 to 6 months to be sure if that is a true negative. Then if someone tests antibody positive, that means they may have been infected in the past, or they may be currently infected. So what do we do in that case? Then you want to you want to conduct an RNA test or send them for RNA or confirmatory testing. So the RNA testing, if that is negative in the bottom right, then we can know that they're not infected. And again, if they're continuing to use drugs or have other risks, if they're at high risk, you'll want to retest them again in a year. But if this was someone that had risk in their past, maybe in their youth they used drugs or they have been in sobriety for a number of years, then they do not, then we can know that they're not infected and you do not have to test them regularly. However, it's this bottom left corner that is critical and really why we're here today. So that is someone who tested antibody positive and also RNA positive, and those are the people we need to link to care. And there's many people out there who've gotten these tests and thought that they couldn't afford Hep C treatment, or thought that, or didn't know where to go for Hep C treatment, or talked to their doctor about Hep C treatment and felt disregarded, dismissed, disrespected because of their drug use or their lifestyle and never went back for care. So those are the people we really want to get and make sure we can link them to care. So let's talk about a case, or a very kind of small snippet of a case. So let's imagine you met somebody named Janet and she's 30 years old. She's new to your program and you ask her about hepatitis C and she says, yes, I remember getting tested, but I'm not sure what happened. I don't remember what the result, I never went back for the test results. So what would you say to Janet? What would be your recommendation to Janet? And can you write that in the chat? And then I'll ask Deanna to help me out again by reading your responses.
First response, recommending getting tested again, redo the antibody test. And I'm seeing someone also commenting that if the person tested positive for Hep C, it's important to vaccinate for Hep A and B. And that's very, very true and something that we want to make sure clients are have access to and are aware of the need for vaccination. Somebody's saying, let's have you do that again. Let's test again. Rapid tests, though, also take into account risk factors or lack thereof. Someone is recommending to say, know your status, assess for Hep C diagnosis and any elevated liver tests. And absolutely encourage to retest and offer hepatitis A and B vaccination series.
Great. Thank you so much, Deanna. It's so true. All of you are right on here. Of course, we would want to make sure she's retested so she knows her status. There are clinics and emergency rooms and hospitals who are doing bloodborne infection testing. We know of a site who tests everybody that comes through for hepatitis B, hepatitis
Somebody's
C.
on.
Sorry?
I can't hear you very well. Somebody's unmuted.
Okay, thank you.
Yeah, Marie.
Let me take a look. Yeah, your audio is just a little fuzzy.
Okay.
By chance, was there anything connected or disconnected from your laptop?
No.
Okay.
How does it sound now?
It's the same.
Oh, no.
All right, I believe folks have been muted. Marie, let's try that again.
How does it sound now?
I'm still hearing it. Deanna, are you still hearing the fuzzy?
Yes.
I'm not sure what happened.
Marie, you might need to disconnect your audio and reconnect.
Okay.
Oh, I think you're back.
Oh, there we go.
Beautiful. Thanks for that suggestion in the chat box and also Watchman for bringing it up. Maria, you're good to go.
Okay, great. Sounds okay now?
It does.
Yeah.
Okay, thank you very much, everyone. Thanks for bearing with us. So of course, everybody recommended that Janice gets tested for the Hep C. I would probably start with the antibody test, depending on your site. Some people are reflex testing, which means a positive antibody goes right to a confirmatory test. So if she were to test positive on the antibody, of course, you would need the confirmatory test, and then you could work with her to link her to care. And I just want to talk a moment about this issue of people getting infected with hepatitis C. So on the left side going down, you see that arrow going down, just to be clear that not everybody who's exposed to Hep C actually gets infected. So some people in a room, a large room, all of us could get exposed, just like if this was seasonal flu or something else. Some people would get sick, not everybody would get sick. With hepatitis C, you can get exposed to hepatitis C, and then if you do get infected, you might also recover on your own. So in some cases, your immune system mounts its own immune response and clears the virus by itself before you go on to needing treatment or anything else. So people who are acutely infected, you might find in some cases somebody gets infected with Hep C, has a little flu-like symptoms, maybe doesn't feel well, and if they happen to show up at your clinic in that moment and they test positive, you might find that they're acutely infected. They're very recently infected. So with those folks, you might wait to see if they become chronically infected before you would treat them. But most of the people we see are people who've had Hep C sometimes for many years. So someone who's chronically infected has had Hep C for more than 6 months. And this is where the liver in many ways is a non-complaining organ. It doesn't have many nerve endings, so that the virus is in the liver causing damage, causing fibrosis and inflammation, causing scarring. That all can be happening without anybody knowing, without really any symptoms, so that over 20 or 30 years, that damage can lead to certainly significant scarring, which is called cirrhosis, as well as it can lead to liver cancer. So there are very serious consequences of people infected with Hep C over time. And we know of many people who have lived with Hep C for 20 or 30 years. Again, some baby boomers who might have had some experience with drugs or other issues in the 1960s, 1970s, and then only many years later going for life insurance, or then finally starting to have complications of this disease, might have known that they had Hep C for decades. And those people who did not benefit from being coached to not drink alcohol or not cause other liver damage or get vaccinated for hepatitis A and B, as was already said. So hepatitis C can be very silent but deadly if not screened for and treated. So speaking of treatment, this is really the good news. And if you are working with anybody who's older, who may have been around during the era when people were getting treated for Hep C, that treatment was very difficult to take. It was like going through chemotherapy. It required weekly injections. People would learn to self-inject themselves in their thigh, in their belly. They would take pills. This was when the treatment was included ribavirin, that was very actually kind of toxic. So people might have been on treatment for a year or more, had severe side effects, felt awful, tremendous fatigue. I know people in that era that lost their jobs, could not show up for work while they were on this treatment. And after all that, it cured only half the patients. So it was agonizing to watch somebody go through all of that to really, in many cases, not even get cured. And in African Americans, that treatment was even less effective. But the really good news is that the Hep C treatment now is very often just 1 pill a day, no injections. It lasts either 8 weeks or 12 weeks in most cases. And really, many people have no side effects at all. If they do, they have very mild side effects. And the cure rates are just incredible. It cures almost everyone. It cures people with comorbidities. It cures people who have had Hep C a long time. It cures people who have not had Hep C a long time. So this message truly has to be gotten out there so that everybody knows this. So this is the good news. And what does a Hep C cure mean? So just to talk about that for a moment, they really define cure when the viral load is undetectable in the blood 12 weeks after the patient has completed treatment. So to actually get the cure, you have to go through the treatment, come back 12 weeks later for a blood test, and if the virus is still undetectable, which in most cases it is, then you're cured. And the cure is called SVR, commonly called SVR, or the sustained virologic response, meaning the virus has gotten so low in your body that it's undetectable, and that has sustained response. And the even more good news is that being cured of Hep C, not only is that virus no longer damaging your liver, but it can really make you feel better in general. There are many extrahepatic manifestations of hepatitis C and other issues, so that you feel better, your liver health improves, and that is all good news. However, the cure does not confirm immunity. It doesn't mean you're immune to Hep C and you can get infected again. So people that go out and use drugs again, have other exposures, can get infected again. I mean, they can be cured again, but that can become a vicious cycle as well. So making sure we understand the cure and that the cure rates are very high. And, we know that a lot of people with Hep C have a history of drug use or even are still actively using drugs. So someone actively using drugs, can they be cured? Yes, they can. There have been many studies that have shown people with hepatitis C that had a negative drug screen when they went through treatment had a 95% cure rate. And another study, even for people with a positive drug screen, had almost the same or even slightly higher cure rate. So this is the good news. People who are actively using drugs, in many cases, are also working and holding down a job and interested in caring for their health and able to get to the clinic to be cured for Hep C. Not everybody who's an active drug user is so chaotic in their life or homeless or in such a difficult position where it might be challenging to get them cured, although still possible. So we're going to just quickly listen to a patient story. So I will launch that now. Oops. Jasmine, can I ask you for a little backup help on this?
Absolutely. Let me try and pull it up.
While you're pulling that up, just want to echo a comment in the chat. And there is a success story of a patient who had chronic Hep C infection. Liver disease stage was F4 and was cured. Jasmine, I think you might have to share your audio.
All right, here we go.
So it's a proven fact that more people are dying from Hep C, from hepatitis C, than from HIV now, And also there's for every one person affected with HIV, there's 5 people affected with hepatitis C. I contracted Hep C from using dirty noodles and shell noodles. They didn't break into the gem.
Okay, sorry, I'm just going to advance to the right slide. Can you guys hear me?
Yes.
Thank you so much. So again, sorry that the video didn't come through well. as Deanna said, it is a peer. He was cured himself and is really kind of talking about the pain he feels for so many people that haven't gotten cured. So really, the importance of making sure everyone gets cured is critical to us, and we're not the only ones. The American Association for the Study of Liver Disease, the Infectious Diseases Society of America, really recommend treatment for all patients with chronic hepatitis C infection. And for a long time, people said, but wait a minute, how can I treat people who are actively using drugs, people who are using alcohol, people who are incarcerated, homeless, or living with HIV? Well, we have seen all of these populations get successfully treated, and we are so grateful for all the Hep C champions on this call who are helping to navigate and support even the hardest to reach populations into treatment and through treatment so that they can be cured. So one population, as an example, people with HIV, there is an increase of co-infection among people with HIV and Hep C. 1 out of 4 people living with HIV have Hep C as well. And people with HIV are at higher risk for serious liver disease and cancer. They're at risk of the disease progressing more quickly and producing more liver damage in them. And they can successfully be treated and cured. So that it is important to get that message out to people who are co-infected.
Maria, I don't want to interrupt, but we don't see the slides.
Okay, so sorry.
Thank you.
Just 1 second.
Let me know what you need and we can help support on the back end.
Okay, I got it. Sorry about that. So what I just discussed was this slide, and that all of the best and brightest scientists in gastroenterology and hepatology and all of the people specializing in this absolutely recommend that everybody with Hep C get treated, and especially people with HIV co-infection with hepatitis C. We know that HIV positive men who have sex with men are at higher risk for hepatitis C, and we need all the hepatitis C champions and other people on this call to help us get the word out about that. So we just want to ask you for a moment, because we've talked about a lot of issues, what are the health promotion messages which are challenging for you to convey? So if you can just type into the chat quickly, which populations or which health promotion messages do you think are most difficult to talk about? And again, I'll ask Deanna if she can help me see what's coming into the chat and read those responses. I see the idea that every part of the works can place a person at risk. I think that's so important, that for injection drug users, it's not just the needle, it's the cooker, it's the cotton that put people at risk. Working with the CGI population, following through from the patient, is something that's challenging. And minority populations, making sure that they don't feel targeted and yet at the same time understand their risks and can get access to treatment. Any other thoughts on this? I think I just saw coming through working with really describing the sex and drug related risks. Not everybody is comfortable talking about these issues, but it's critical that we get to the nitty gritty so that people can understand their risk. Homelessness and being able to make it to appointments. So identifying people who are homeless with Hep C and then actually linking them to care is certainly challenging. And then there are many sensitivities and stigmas related to practicing safe sex as well. So thank you. I think there'll probably be more things that come into the chat. I tried to cover some of them, and we're going to need all of you to use all the skills that you have, as well as the many resources in this toolkit to convey these very important health promotion messages. So we've been going here for almost an hour, and I thank everyone for chatting with us, for participating. And we are going to take a very short break, just a stretch break. So I will ask my colleagues if there's anything they want to add before we step aside for a moment and take a stretch, use a restroom, and come back. But according to my time, it's 1:53, and we'll be starting back in 5 minutes.
Okay, who else was woken up with that sound? Great. Okay, just checking that you can see my screen.
Yes, we can.
Yes, thanks.
So welcome back, and I am going to cover information around what is navigation and the navigation steps that we have identified as part of our hepatitis C community navigation model. And so obviously there's so many details and intricacies about navigation that we may not be able to cover today, but we are here as a resource if anyone has questions after. And then I'm also learning a lot from you in the chat, and so I like the collaborative community of building knowledge together. So please continue to share in the chat. Marie and Nira will be monitoring and hopefully answering questions or bringing stuff to my attention. And so I first wanted to, begin with this description or definition of navigation that states that health navigation is an approach to improving healthcare delivery that helps people access the care they need. And so historically, navigation has been used for cancer care, HIV, and chronic conditions. But the core of this approach is that it is patient-centered and focuses on building trust with the patient and meeting individual needs beyond just the spread or preventing the spread of disease. The overall goal of navigation is to understand the health needs of the client and make sure that they receive optimal care regardless of their race, their gender, socioeconomic status, and other factors that may make it harder for them to get good care. And in a lot of work, the navigator, particularly in this model, is at the core of the of providing services, but definitely is not the only person working with the client. And so we really want to emphasize the importance of building a care team, that the navigator is not working alone. I saw some people in the chat also mentioning that recognizing and presenting to the client like the whole team that is behind them to get them through the steps of hepatitis C care. So we have here many areas of services such as clinical care, health homes, social service and benefits providers, mobile unit staff, transportation services, substance use and harm reduction, pharmacy, family partner, and support system. So this also gets us to ask the client or the patient who else is there for them. And we might also encounter that in some situations, the navigator and the Hep C care team might be the source of support. So acknowledging that and the role that has in a person's life and process through the treatment and cure process is important. So first acknowledging all the different aspects of the person's care and who should the navigator be in contact with, and in constant communication to make sure that the patient is receiving all the services they need. Now, from a patient's point of view, this is what the steps of Hep C care and cure looks like. We begin with getting tested at number 1, then seeing a doctor, getting the right treatment, getting ready to start treatment, and getting your care covered to ultimately accomplish the cure. And so this looks like very simple in these ways, and these are the steps that we also use for our hepatitis C care cascades. But I'm gonna get into what the navigator's role is throughout each step. And ultimately, you know, we have this message here of Hep C is a big deal, but it can be cured, and you don't have to go through it alone. So really emphasizing that the navigator is there to, that is somebody that the patient can trust and that will provide support. Now, the Hep C navigation steps, so taken from the steps of care and cure, starts at outreach, identifying the people that should be receiving services, then making sure that testing is completed, to linkage to care, completing the medical evaluation, getting into treatment, and also finally ending with after treatment liver health. So all of these steps I'm going to be discussing in the next few minutes. And I also wanted to highlight that we have a health promotion guide as part of the Hep C Community Navigation Toolkit. And this provides specific talking points that navigators can have with, handy when they're having discussions with the client during each step. So all of these tools will be provided to you after the training. And I just wanted to highlight that we have this health promotion modules that could be used as part of your health coaching. And let me just briefly show you what it looks like. Oops. So all of these health promotion guide modules have a very specific structure where you would see first to assess the need. So those are questions that you can ask the client to just get a sense of where they are in terms of knowledge and needs. And then there's a section for telling patients. And so that will include key messages that you can use, and also a step for reviewing information. So following that teach-back method of after you have explained key messages for hepatitis C, what does the patient understand? And so really making sure that you're checking and clarifying anything that may have been misinterpreted. And finally, making a plan. So what happens next? So we have modules for Hep C Basics, which includes the key coaching messages, and also a module on getting ready for Hep C care, getting ready for treatment, and after treatment. So pretty much just to give you a brief overview of the health promotion guide, we have the assess need with a sample question of what is Hep C, then telling the patients the key messages, and then reviewing information with them. So tell me, what are the symptoms of hepatitis, or can hepatitis C be cured, or any other questions like that. And these are examples, especially if you're new to this role, that you can familiarize yourself with, and you may start to use this as a script But this is definitely meant to be a guide, so you don't have to say it word by word. We definitely encourage navigators to become familiar with the information so that they can bring up these topics in a natural way, in a casual conversation with the client. So our first step is outreach. And so in this step, we want to find out who are the people at risk for or living with Hep C. And the way to do that is by working with members of your organization, working with community partners, or working with the patient or peer social networks, right? So you may be getting patients in many different ways. So this is just a reminder of all those avenues for identifying people who may need services. And that it is important to build those community partnerships to not only find the person, but also to follow up with them later in case that you may not see that person in a while, but they can still remain engaged in a different setting. But outreach is not just about looking outside of your organization, it's also about looking within. So something that we do when we start our navigation programs is ask the organization to review current patient lists. So you may have access to this now, or this may be something that you can bring up, but it's important to just do a query of your organization's records to find out who has been previously tested positive for hepatitis C or who has never gotten a hepatitis C test. So that can help you create prioritized lists that you can follow up with patients and help you build that caseload. And something else that you can do from a navigator standpoint is to offer assistance to other members of your organization who may be doing parts of the care cascade. So there might be a testing team, but they might need help linking people to care. So that's where navigators can come in, and also supporting providers in following up with patients, motivating them, and ensuring that they are retained or return to care if they have not come back for appointments. And some of the methods that you can use include cold calls and letters. Definitely check with your organization's policy, making sure that everything is being done properly. But that is one of the strategies that have been used in many programs. And also identifying another service provider that is currently working with that client that can make that warm handoff or introduction with you. During this process, it's important to know how you will be keeping in contact with that person. And we have here as a screenshot of some templates of business cards that we developed as part of the model, and primarily for peer navigators and patient navigators who either would work on a stipend basis or part-time and did not get access to business cards. So as part of the program, we have this tool available, which is critical for making that connection with the client. And hepatitis C patients can get lost to care for many reasons that all of you have mentioned in the chat, whether it is homelessness, any other type of incarceration as well, and something else happens in that person's life that they don't return to care, whether it is also the experience of stigma that may not want that leads that person to not come back. So there are many strategies that we have found over the years and that are included in a handout that's called Keeping in Contact, and that's also linked to the slides, which you will have access to. But it's important to follow up with patients to maintain engagement and letting patients know how they can reach you. So in part of the Keeping in Contact handout, there are many tips for how you can stay in touch with them, whether it is if they have a working phone, or someone else that is involved in their care, or in some cases, that person may be active in social media and going to using local Wi-Fi or libraries to access social media. So that's another way of getting in touch, or setting up Google Voice or any other type of free services for calling or leaving voicemails. But also knowing where do they usually go? Do they hang out in a particular place, a park, or do they go to an organization continuously so that you can find them there if needed? The next step is navigation through testing. And so we covered the two-step process, and the role of the navigator here, whether you're also a tester or not, it's important to explain the testing process. Something that I probably will continue to say through this presentation is that navigator's role is primarily on health coaching and managing expectations, which usually that is found to be one of the challenges when people, especially that have been failed by the system many times, are promised something or expect something and that doesn't materialize. So it's really important as navigators to explain what the process looks like, what will be done, and what would happen if things don't work out in that way. And during this navigation through testing step, the navigator should be aware of the testing processes at their organization, or with a referral partnership that you have if you don't conduct testing yourself. And what can the person expect, especially around test results, and to make sure that if they need support for attending those test result visits, that the navigator can be there for them, and as accompaniment, or if they're conference call and whatnot. And also what would happen if the person is negative, and what will happen if the person is positive for hepatitis C. So we have also here a screenshot of our Steps to Hep C Care and Cure handout, which is another tool that you can use to have those discussions around managing expectations. So if we were doing a full day training, and probably with more in-person capabilities, we would have a conversation around planning and self-reflection. But I'd still wanted to post this here for you to keep, or if you want to think about it now and answer in the chat, that could be fine. But it's important to do a self-reflection of the program. First, asking yourself, does every patient receive Hep C education? Has every patient been tested? And what Hep C tests are done in-house? Where do you refer? And how do you and your program support patients to complete necessary testing? So these are self-reflection questions. If folks want to chime in the chat, if there are ideas that already pop into your head, and especially given the new universal testing guidelines, with if you have been working on implementing that, we would love to know.
Deanna, I'm not seeing anything in the chat just yet, but I'm sure people are thinking.
Yeah, and no pressure. I know this is very on the spot.
I
But
see one person added that they're including testing sites in all of their community education events. So it sounds like bringing Hep C to the community by bringing Hep C testing to community education events. That's a great strategy.
absolutely. Right. I see another one on doing testing at all our offices. So that's important as well, making sure that the service is available in all of your locations. Okay, I see an interesting question. Can health navigators use social media to keep in touch with patients who test positive? My health system seems to have HIPAA concerns about doing this. So generally, some programs would use like a program approved social media account. But some other programs have also created a closed Facebook group, for example. And so that won't show up in a person's like social media history. What we encourage health educators to do is create also their like a separate social media account that's only used for this work, and that can be used to follow up with people as well. And the social media conversations, definitely there's another conversation. Sorry, how do you do that first interaction? And so something that even in the New York City Health Department, when we do calls to patients who may not know who we are, we never say like that we work in the hepatitis C program. So you want to make sure that before engaging with that person that you are talking to the right person.
And Deanna, someone also talked about offering incentives. So if your program is in any position to offer incentives to help people get through the steps of testing and coming back, that can be very important also.
Yes, incentives, that's a hot topic. There isn't funding, enough funding to do so, in the programs want to, that would be, super effective. But we have listed also under incentives, like it may not need to have a gift card, although some of our programs have used the 340B program and other grants to support staff, but also to be able to purchase gift cards or promotional items, t-shirts, things like that. And so another way of looking at incentives is like not just like what are the t-shirts or the water bottles or transit cards that they can use for transportation, but how another incentive is how coordinated your services are, that becomes a motivation for the client. So a lot of our programs have become pretty much, one house for every type of service that the clients require. And so if that can be done at your organization to make sure that the client is accessing services seamlessly, that's another form of incentive. And yes, I'm seeing Deborah. We also offer Uber rides for participants. Yep, some organizations created Uber Health accounts that can be used for that as well. In New York, we have Medicaid transportation service. And so that Medicaid patients can use for medical appointments. And it would be one of the cab companies in the city. There are several in each county that can be used for that. We offer $10 gift cards for people who test and sign up for our harm reduction program. Yeah, so the incentive also may not need to be even, extravagant, right? $10 can mean a lot for someone. And testing is always free. Yeah. Great. So next, the next step, the third step is linkage to care. So we found the navigator would work with the client, get them through the testing. So they came out positive, and what happens next? So linkage to care is really important. And on here, we're also referring to linkage to care as not only the referral you're making, which should be culturally competent. So depending on the needs of your client, is the provider affirming to people who are immigrants or people who use drugs, who, particular sexual orientation, LGBTQ, or just as involved, or if they have mental health needs. So all of these things should be taken into consideration when making a referral. And, and then linking the patient to care. So the next step within this linkage to care process is not just making that referral, but also making sure that the person attends the appointment. So in doing that, it's important to identify what are the best times to schedule the appointments. And so this is where, we really want to be patient-centered and provide schedule an appointment that would work for the patient's schedule. So if you know that they're going in for methadone, or they know that they work nights, so an appointment early in the morning may not work for a particular client, or a specific, just making sure that you are having this conversation with the client to find out what their schedule looks like that would work for them, so that you can coordinate better and also accompany that person to appointments. And so this can look different now that we're in a pandemic, and a lot of things are being done through telemedicine, but the essence of this remains. Like, are we scheduling appointments that are feasible for the client to attend? And return to care. So you might find that some people began this process many years ago or last year, and they didn't return. They didn't complete their medical appointments. Something happened, they moved, whatever it may have been. It's important to check in and find out what would make it possible for them to successfully complete the process. And that might involve, the navigator actually having call reminders, or using this, we have this care plan template that navigators have used to write down all the people that are involved in the care team, and also the program goals that we have set up for the program, so that they know what has been done already and what is left to do. Especially around referrals. During this linkage to care process, you're also making referrals for another supportive services that would make sure that the client can start treatment seamlessly. Okay, and part of this step is making sure that you have a strong referral system. And I know that in some environments, some settings, this may not be a large list in terms of availability of providers, but it's still important to know what services and what the provider that you're referring to does, and how they can work with your client. So you should learn about the referral site, their approach to treating the clients you work with, what documents do they require, what insurance plans do they accept, what would be the cost to the patient, And if possible, touring the facility and meeting the staff. This is information that then can make you confident in the information you convey to your patient, so that the patient already knows what to expect when they go in or when they meet with the service provider. And one of the things that we also require as part of our program is setting up a linkage agreement. And this is something that's also known as Memorandum of Understanding, or MOU. And even if it's not a formal written agreement, that there is an understanding between you and the referral provider of what to expect. So if I send my client to you, how long will it take for them to get an appointment? Can we make an agreement that they can be seen within 2 days or within a week? And also, as part of that linkage agreement, is ensuring that that you also have access to get information back. So for us, navigation through Hep C care is not just about sending the person to that appointment and that provider, but also following up. Did they make it to that appointment? What's next for them? Have they completed treatment? What is the status of their treatment? And so some of that information may not be disclosed to you if it wasn't agreed upon in the beginning, in terms of like if there are requirements to adjust or set up a HIPAA agreement with the organization so that the client consents to sharing that information with you. So all of those considerations should be made when setting up a strong referral system. Now, there are some tools that you can use for linkage to care. In New York City, we started a site locator using Google Maps that then became, was incorporated into an agency tool that is now called the NYC Health Map that you can see on the screen. So this is a way that the public can look up a hepatitis C testing and care provider that based on their zip code. And there are similar national site locators, such as the American Liver Foundation provider locator or ones from the CDC. But the main point here is that it's important to identify and create a local site locator, even if it's just a list that you have that you can share with your teams or your local network, and on how to refer clients. It's important to identify resources and referrals for uninsured patients, especially around do they have benefits enrollment, or are they a federally qualified health center or public hospital. There might also be programs that are grant funded that would cover the cost for uninsured patients, and obviously patient assistance programs from the pharmaceutical companies. There are also, other resources that can also support the making up the cost that's left for the patient to cover. And there are some resources that we will share at the end of this training. Another tool includes this appointment card that was created not just to show the dates and times for the next appointment and what to bring, but also on the back side has a patient bill of rights. And so this is based on the New York State patient bill of rights, but the template is available so that you can make changes that are appropriate to your jurisdiction. But this is an important patient advocacy tool because we noticed that there were many clients that didn't know that the peer educator or patient navigator could go with them to appointments, or that they had a right to an interpreter or a translator, even if it was a telephone service. So this is a tool that would support that self empowerment to patients, to know that they have rights. And also the main one that I think should be highlighted even more is that a patient has a right to receive medical care with respect, without discrimination, and in a clean and safe environment. And, you know, to some extent, it's also important to highlight that the patient also has a right to refuse services if they know how this will affect their health. So this gets to another conversation around, working with the client where they are. So if they're not ready yet, they have the right to make that decision, and you can still be there to remind them and let them know of the opportunities that are available to them. There's also a template for recommendations for hepatitis C screening and treatment in people who use drugs. So this is something that we developed this year as a way of putting it all together in one sheet of paper, key information of the testing that is needed, especially the guidance to make sure that people who use drugs are tested at least annually for hepatitis C, and that all people who use drugs with Hep C should be evaluated for treatment. And it is a critical process, a critical step in hepatitis C elimination to treat people who use drugs and cure them. There is a section in the template that would have health insurance information. And in New York, we're lucky to have changed policies that enable for the removal of certain restrictions. So depending on your jurisdiction, this section on health insurance that prohibits medications for people who use drugs, you might have to tweak that. But it's important to just note what is the current state of affairs where you are in terms of access to hepatitis C medications and also prior authorization. And the last section in the template, I'm just highlighting it here because we added this this year in this focus to integrate our Hep C and overdose prevention work. So that the teams that are doing this work are coordinating with each other, especially in harm reduction settings, and making sure that people are receiving a cohesive messaging around not just overdose prevention, but also hepatitis C prevention and linkage to care. And in a lot of ways, there are many studies that have also found supporting people to get into substance use treatment, or even using, not just to stop using drugs, but just to manage their drug use is another strategy to prevent hepatitis C infections. Okay, so another set of questions for program planning, and this refers to the linkage to care process. So some questions that that I recommend asking is, where will you find patients in need of linkage to Hep C care in your organization? And so this goes back to, do you have a patient list, or internally, have you looked at the other programs in your organization that may be serving hepatitis C patients? And so just making sure that as an agency, do you know who still needs linkage to care? And how often do you access patient lists for linkage to care? In our programs, it varies. Some navigators would get daily lists. So if someone gets tested today, they'll get the list, the name of that person, so that the navigator can follow up with them. But some programs might get a list on a weekly basis, every 2 weeks, and on a monthly basis. Regardless of how often you get it, is important just to make sure that you are getting a list that you can work from. especially to make sure that any patient that is interacting with your organization is receives a coordinated response from the organization in terms of services. What is your linkage to care process, right? So do you offer hepatitis C treatment in-house via telemedicine? Do you have a treating provider that comes in sometimes? Or where do you send clients to? All of that information is key to make sure that you are aware of what you would do with the client. And how will you keep in contact with the clinical provider you are referring to and the patient to support complete treatment? So again, going back to this linkage agreement, but generally just establishing a communication channel between the clinical provider and the navigator, so that if anything comes up, there's an avenue already created to check in. And this is usually shows up as like case conferences. So a lot of organizations have internal case conferencing happening, but there might also be the need for having a monthly call with the clinical provider you're referring to checking on the clients that you've referred last month, for example, and find out what's going on. So again, if you have any thoughts that you can put in the chat. I know I've been talking for a while, but I'm looking forward to any comments that you may have on this linkage to care, navigation to testing, and outreach. Oh, great, Nira. I see that you have shared a sample linkage agreement for Hep C referrals. And I'm glad, Jamie, we have created a referral book that includes all of the information, and we can check 3 times a year. Yeah, that's also important. Like, how often are you checking those referral lists, making sure that things are up to date. So I see a question from Carla. This presentation is being recorded and will be available on the website, the Hep C Community Navigation Toolkit website. So we'll be sharing all those details after, or at the end, I should say. Okay, so I'm gonna ask Jasmine to go ahead and start setting up our next activity. So this is an opportunity that we wanna make sure that you can also get to talk to other folks, other attendees, and to check your knowledge in some ways, but also learn from you. So we have a case study, and this is James, and James was diagnosed with Hep C while incarcerated. He was released 3 months ago. He lives in a hotel and is in a job readiness program. James injects drugs. He's not interested in starting Hep C treatment because he has heard that abstinence is required. My question to you, and you will work on this as a group, is what are the barriers to Hep C care for James? So based on this very general description, what are the barriers to Hep C care that you notice? And also, what would be your approach to link that person to care?
All right, with that, there will be a prompt in just a minute that transfers into a breakout room with a few other folks that are on this call. And so we do just want to mention this is, a more intimate setting for you to discuss this case study amongst your peers and ask yourselves, what are the barriers to care for James and what approach would you personally take? So feel free to turn on your webcams. You'll be able to unmute yourselves, and we'll have 10 minutes on the clock. So we're going to go into breakout rooms, and we will reconvene automatically after that 10 minutes.
Great. So I hope that you were able to come up with some ideas, but if you can write it in the chat, what were some of the barriers to Hep C care for James? And I'll just read it again. James was diagnosed with Hep C while incarcerated. He was released 3 months ago. He lives in a hotel and is in a job readiness program. James injects drugs. He's not interested in starting Hep C treatment because he has heard that abstinence is required. Great motivational interviewing approach, definitely. That's really at the core of navigation work, really to identify what what is the client interested in and working from there. And, you know, how do the Hep C treatment goals would align with that person's life goals as well. I see continued drug use, no transportation costs. So those are the barriers to care. It may help if you could speak with him regarding the Hep C treatment program, stating the positive aspects, absolutely. Maybe providing him with bus passes. And our unit has our own food pantry, perhaps offer some food, anything to develop a rapport or relationship with the client. Absolutely, yes. Give the patient fresh needles in the hope of him stopping drug usage. Sharing appropriate education and building trust, referred him to a harm reduction program. Right. So, I mean, generally speaking, our goal, you know, is not for him to tell him to stop using drugs. That would be a decision that he has to make on his own, but letting him know what are the opportunities available. If that is something that he's contemplating, you know, maybe having a conversation about substance use treatment. And, but overall, and I think this is also part of really understanding what his needs are at the moment. You know, James was released 3 months ago, so he's in a job readiness program. His priorities might be in just getting his life together right now, right? And so even though we really want to push our Hep C agenda, it's also important to recognize what he's ready to do now. And so that might happen with building rapport, like a lot of you mentioned, providing some of the survival needs, you know, addressing those survival needs that he may have. And something else that, depending on the state that you're in, is looking at what the requirements are for treatment. In some states, you know, abstinence is not a requirement. So you might want to educate that person if that is the case, and letting them know, you know, it's okay that you're still actively using drugs. That's, you know, it's not, it won't interfere with you getting treatment and getting started and completing and getting cured. So, but if abstinence is required, you might just want to touch upon what would be the process of what has to be done in order for them to start treatment. In New York, this is some of my experience in the programs that I've worked with. Some organizations would work with clinical providers who are very affirming to people who use drugs. And so they came up with a plan of like, we just need a drug test that comes up negative. So please be abstinent for, you know, a couple months, and we can get those drug tests done and get you into starting treatment. So even coming up with strategies in that way, that person doesn't necessarily have to stop using drugs altogether, but if that is for a short period of time, if they are capable of doing that, that is possible, so that they can get Hep C treated. Yeah, so I echo Pike comment and giving him as much information as possible to make an educated choice. Absolutely, you know, you're just letting them know what's available to them and that you're there to help them out. And it's really their, they have the power to decide what they're ready for at that moment. So with this is another segue of the patience that is required as part of doing navigation work. for hepatitis C. Even though we really want to get people into treatment, getting them cured is there, we still have to be patient and accommodate to that person's readiness. Okay, so the fourth step in this process is medical evaluation, right? So we made it through linkage to care. The person has an appointment for their hepatitis C clinical care. And during this step of medical evaluation, this is usually requiring getting the full medical history and treatment history of the patient. So if they were treated for Hep C before with interferon or with another DAA, that's important to know for the clinician to make a decision of what is the recommended treatment. And reviewing current medications and herb supplements. So in letting the patient know that they should bring a list of medications and that they're currently taking. Since a lot of medication and herb supplements are processed in the liver, that's something that's important to note when treating hepatitis C. And this process would involve a physical exam with blood tests, liver health assessment for fibrosis level or liver disease stage. And also if the person is cirrhotic or match other criteria for liver cancer screening, that should be completed. So again, drug testing would be done at this stage as well if it's required for drug prior authorization. And like a lot of you mentioned, making sure that the person is also completing hepatitis A and B vaccination. So we want to make sure the person is vaccinated because that would be two viruses that they wouldn't have to worry about affecting their liver. Okay, so we've come to this point of prior authorization process, which remains to be one of the biggest hurdles in making treatment available to everyone living with Hep C. So I'm not going to cover this in too much detail, but we just wanted to acknowledge this process and also making a note here as part of the building that care team that the role of the pharmacist is important in this process. So as a navigator, we generally don't require them or ask them to be responsible for prior authorization applications. But, as a navigator, you should still be aware of what the process involves, especially if the patient has to sign paperwork or the patient just wants to know how long it will take. So you should be aware of the basics of this process. And in short, it starts with the initial physician's visit, so that medical evaluation visit where the prescription is prescribed and is processed, and then the prior authorization application begins. So this is where we've also have available a checklist that was created by the New York State Department of Health that could be used as a template for other states. And it would include all the tests that are needed, all the descriptions. There are statements from the medical provider that would be made, any information that is required for that application. The importance of that is that one of the main reason for denials for prior authorization is incomplete information. So we want to make sure that that application goes in with all of the information filled out. An approval time could be a few hours to 3 months. So this is why it's important to work with a pharmacist or a specialty pharmacy as well, who are versed in this world of health insurance and prescriptions, and also knows all the tricks that that they have to make sure that these applications are approved. If the application is denied, there's usually an opportunity, or there's always an opportunity for appeals, and it could be a first appeal. If that's denied, then there's a second appeal that could be made, and a third. And there are many resources also out there and organizations that can help in advocating for the medication to be approved by the health insurance company. Usually there's also a state attorney program that this type of cases can be reported to and can be brought to the attention of the state officials so that they follow up with the health insurance company. But in many cases, the process has been streamlined, and we also noticed some changes with the COVID-19 pandemic, that some insurance companies were a little bit laxed on some of their requirements for hepatitis C prior authorization applications. Once the application is approved, then the pharmacy would then disperse the medication. And usually if you're working with a specialty pharmacist, the pharmacist would also have a counseling session with the client to talk about the treatment that was prescribed, and also assess for treatment adherence, making sure that everything is set up to complete treatment successfully. So the patient has the medication on hand, and we arrived at the 5th step in the process, which is treatment. And in this step, it's important to work with the clinical provider to review the recommended treatment for the patient, make sure that patients know what treatment involves, work with the care team to select the best time to start treatment. So, I say that last one part mostly as a way of that actually should occur before the prescription is sent in, because, we want to honor the agency of the patient. And so if there's something else going on, maybe there's another comorbid condition that has to be treated before hepatitis C. So anything that would come in the way of delaying treatment, and especially also if it comes from the patient directly, if they know that they're not ready to begin. That conversation should happen before obviously getting the medication approved. But throughout the process, we also encourage you to use a treatment planning form. Again, these are all optional materials. You can also just review them, and just for awareness of what type of information you should be looking out for. But this is another tool that would have the doctor's appointments that are needed for the person to come back for continuous testing to make sure that the medication is working. And there are some tests that the insurance company requires before dispersing the second round of, not round of treatment, but they don't disperse the whole medication for the whole treatment duration. So they'll do it in 2 batches. So there are tests that are required in order for that to happen. So making sure that the patient understands all of their doctor's appointments, and that they also get to see how their viral load goes down. It's another way of motivating that person that they are doing something for themselves that is working. And so, at the end, they'll also be able to know and to see the whole journey, and really look at what they have accomplished. So in the treatment planning form, there's also a section for my care team, which would have contact information just for the patient to know who to contact if they have specific questions, and other notes of medications that the patient is taking, and on any side effects that the patient may have. Questions for the doctor as well to prepare for the next appointment. And a note on like the side effects question, we ask that our navigators check in with the patient 3 days after starting taking the medication. And the reason for that, it doesn't have to occur within 3 days specifically, but within a week or shortly after starting treatment is essential for the patient just to check in with someone to make sure that everything is working properly. And, you know, there aren't many side effects now with the new medications. Many people report not having any side effects at all, but it's still important to make sure that if something comes up, that it is addressed quickly, and also making sure that the patient has a system for reminding themselves of when to take the medication, if they put it with another routine that they have during their day, and to be able to make sure that they're taking their medication as prescribed. And if they have any questions, that can be conveyed to the doctor or the clinician as soon as possible. The main reason for that is because we want to support treatment adherence and prevent treatment interruptions. And so in terms of treatment adherence, it's really, really important to emphasize that they have to take the medications as prescribed. And that means at the same time every day, and depending on the medication that they're using, if it's 1 pill or 2 pills, so that they know all the logistics that are involved. It's also important to discuss what time of day the medication will be taken and where they will be stored, just so that, you know, there is a plan set up for that. And we're basically making sure that everything has been reviewed thoroughly and there are plans for everything. The patients should also be made aware of any side effects and what to do if they have side effects. And make sure that you tell them to notify their doctor or clinician, but even more important, to not stop taking medications on their own. And so they might be feeling fatigued, but is it really caused by the medication they're taking? So definitely, if anything happens, they should have an immediate call, or as soon as possible, contacting their clinician, discuss it, and figure out what to do next. Now, if the patient stops taking their medication, which has happened, it's important to let them know to not double down. So if I miss my medication today, I should not take 2 pills. If I usually take 1, I shouldn't take 2 pills tomorrow. Just take the next dose when scheduled. So, okay, I missed today, I'll just continue as if nothing happened. There might be some additional, conversations with the client if they stop taking the medication for more than a day. If it was 3 days or a week, then that really should be something to be discussed with the clinician if there's any impact in the effectiveness of the treatment. And so again, working with the client to inform the provider of any interruptions is important, and discussing the reasons for the interruption. Like, can this be prevented in the future? What happened? And assisting with overcoming those obstacles. This is also another chance for you to check in on how you're supporting that patient, and if there's increased efforts from your end in making sure that they're adhering to medication. So if initially this person had said to no, I just want a weekly check-in call, offer to call them, every 2 days or every day if needed, just to make sure that you are supporting them in the best way. And obviously provide health education and motivation. Why they stop taking the medication, reinforcing the importance of taking the medication as prescribed, and just identifying any gaps in information or misunderstandings. Okay, so in the chat, we would love to know what are some of the resources that you can use to support adherence. So again, please feel free to jot it down in the chat and let us know what are some of the resources that you have used to support adherence, or that you think are important.
So, hey, Deanna, we're seeing someone who posted that contact with their case managers is important, and providing medication storage and management support for people who are unsheltered is important, as well as daily observed dosing if possible with incentives. So that is true. Some sites can do directly observed therapy, which is important. Free harm reduction services. Also incentives and appointment cards can be helpful, as well as bus passes.
Great. So yes, a lot of you mentioned some of the resources we had in mind. Definitely, directly observed therapy is a strategy to support treatment adherence. And this can be, because of many reasons. We've noticed that it's particularly useful for homeless clients, so that they don't have to worry about where they're storing their medication, even though, as someone mentioned, the organization can also support storing the medication for them. And so that's a great strategy. So definitely we want to make sure, it sounds very simple, but a simple call from the navigator is a strategy to support adherence, text reminders, and this can be done, manually by the navigator, but I know that there are some electronic health record systems or patient communication systems that would automate reminders, calendar reminders, helping the person set it up on their phone in their calendar so that they get an alert every day at the same time to take their medication. And with that, identifying another daily routine. So if they also have, they have a ritual for taking their tea at 2 p.m., that you can use that as a strategy to take the medication at the same time. Or in some cases also, and this is a plug for coordinating services across different programs, is, there is a value in combining substance use treatment and hepatitis C treatment. So there are maybe some methadone programs where the medication for Hep C can be provided after the person comes in for their methadone. Having more frequent calls or visits if needed. There's also visit and nurse services that can go to the patient's home and be able to provide the medication or check in with them about their medication adherence. And family or buddy support was something else that we wanted to mention. Again, this may not be for the same for everyone, but there might be another person in the patient's life that might be the source for motivation to get into treatment, and they can also be a support in treatment adherence and completion. Great, thank you all so much for sharing your thoughts on the chat. And so one last thing that I wanted to mention before we go on another break is uncompleted treatment and getting cured. So some considerations. So when a patient is cured of Hep C, it's important to know that they do not have the infection, they cannot infect other people, and fibrosis can regress. This has been mentioned in the chat also by some of you, that their health overall improves when the person completes hepatitis C treatment and is cured. And some other things to keep in mind is that they will always test Hep C antibody positive. So if we remember the 2 steps for Hep C testing, antibody positives only tells you if you were ever infected with hepatitis C. So it's important to make that distinction and to explain to the person if they're also actively using drugs, or it falls into a category where they will be getting tested for Hep C on an annual basis, that they are getting the RNA test, because they will always be positive for Hep C antibodies. And keep in mind that the person can get infected again, we cannot say that enough, and that they may need follow-up screenings to monitor liver health. So even if the person has completed treatment, it would be the conclusion of your services, but they, if they are at risk of developing liver cancer, if they're cirrhotic, there should be a plan for liver health monitoring, making sure that everything is fine. Okay, so I'm gonna, we can go on our 5-minute break now. Okay, welcome back from the short stretch break. So we have a couple of 2 more sections to get through, very small sections. I'm going to trying to summarize a lot of the information that we have already covered in the conversations we've had on the chat. So I just wanted to end in the final step of navigation is the after treatment liver health. So this is where, we've already talked about, or the completing treatment. And so this is when you would have conversations around what does cure mean and what is left for the client to do. If there are additional referrals that the person should be receiving, and to help them with their next needs, liver cancer screening to be done. And there are some tools available. I wanted to highlight the Hep C, your Hep C free pocket card that was developed by the AETC. And is another way of giving like a certificate of cure to clients to let them know that they accomplished a big milestone in their health, and that they are a leader in ending hepatitis C. There are some reinfection prevention strategies noted here. A lot of you have mentioned this in the chat, making sure that the person is accessing harm reduction services, and that they understand, how they can get reinfected and how to prevent that. And so finally, we want to make sure that we're celebrating the patient's success. There are many reasons and many steps along the way that you can celebrate that patient's success, and as part of that motivational interviewing, it's about acknowledging the person's strengths. If they attended appointments, if they finished the paperwork for prior authorization, they started treatment for either Hep C, maybe HIV or substance use, that they are adherent to Hep C treatment, that they finished. And for folks who are co-infected, this is a tagline that one of our peer educators came up with, of being HIV undetectable and Hep C cured. So celebrating all of these steps and, you know, the recognizing the effort that the patient has put in to complete that, it's important. Just wanted to, you know, highlight in the slide, you see a link to the New York State Department of Health Hepatitis C Cure Day Planning Toolkit. Obviously, that was created for in-person celebrations, but if your program wants to do a dinner or a fashion show or some type of event, just to recognize and congratulate and celebrate the patients for completing treatment. That's always a way of uplifting people's stories and also making space for anyone who wants to become a mentor for other folks. So this is another opportunity where you can ask your patient that got cured if they are willing to share their story to motivate other people that are contemplating this process. So in summary, we have the ladder of Hep C cure, and we start with the person being unaware of the status to get through the next steps. So this is just to summarize how navigation services support people getting cured for Hep C. You know, we start with outreach services, linkage to testing and care, and linkage to telehealth support, I should say, sorry. Especially now as folks are accessing care via telemedicine, there's still an additional layer that some people might need some support in getting set up for that. And then to get that person through diagnosis and linkage to care, the navigator would do an assessment, referrals, care planning, and a lot of advocacy and health coaching to finally get that person through treatment. Woohoo! And you know, and the navigator in this step would provide that treatment adherence support, reinfection prevention, and harm reduction, and liver care planning for the future. So we just wanted to put in a little bit of information here on telenavigation, especially as telemedicine has become more popular and doable for hepatitis C treatment and opioid use treatment. And I wanted to just get a sense from you, if you are providing telenavigation, what is working well for you and what is difficult at the moment. So just take a moment to write in the chat what your experience has been like providing telenavigation. Great. I'm happy to see so many positive feedback. It's been amazing. So there are still restrictions in like getting in touch with people. It has been difficult. Yes. So definitely echo a lot of this feelings. And so just wanted to emphasize that, yes, Marcelo, telenavigation is powerful. And so telemedicine has become increasingly available for Hep C and opioid use disorder treatment. We have a couple of resources to build the capacity of organizations to do this. And so we'll be sharing that also with the slides. And some of the successes that we've seen is the ability to support patients who cannot make it to the healthcare agency. So whether it is that the person is in a rural environment, or they have special needs, or they just have a very busy schedule, this has been a great success to make treatment available to those patients. The navigator can also serve as a physician extender, being that connection to the clinical team, particularly if the navigator is in a clinical setting, and to assist the clinical provider to prep and follow up with the patients after the visit. We've seen improved care integration where the person can have virtual appointments for all of their needs in one day, or it just brings care to the person in that way. And so we're noticing that with buprenorphine being available virtually, and Hep C treatment. However, there are still some challenges, right? And so we acknowledge the lack of access to phones or computers, or internet access, or even just low tech literacy. So those are considerations to have in mind of how to support folks who are in these situations. There might be some people who have patient privacy concerns because they might be taking the virtual call in their home, and they don't want their household members to know what's happening. So those are some things to keep in mind. There's also the lack of walk-in referrals for immediate care. And this meant a disruption in access to care for a lot of our clients who needed abscess treatments or any other urgent care. And they didn't want to go to an emergency room because of bad experiences in that setting.
Wilson.
Okay. Disrupted communication with homeless patients. So yes, I see folks writing that in. They lost touch with patients, and we saw that as well in New York City, and especially for folks who relied on the physical space of the organization for survival needs, whether it was a place where they can rest or get food, or also use that as their mailing address or for medication storage. And we also noticed that for homeless patients, they were moved. And so the organizations doing outreach couldn't find them in the usual locations where they would go because they were moved to different parts of the city. In-person Hep C diagnostic testing and medical evaluation workup, it's still required for treatment. So you still have to support that person to make it to that appointment to get all those testing done. So that's a role of the navigator that is essential even with telemedicine. But we noticed that the navigators can help find those places where they can go for testing, arrange the transportation services for that service, and help reduce wait times as well. And so with that, I wanted to end with this quote from poet and activist Maya Angelou, because I see it fitting in this work and a lot of the work that you do, that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I think this is a powerful statement to, even in the face of COVID-19, the navigator can be there to even just be a support, have somebody to talk to, that they know that they can trust, and so and just generally be there. So, what questions do you have?
I think we have about 10 minutes for questions, and then we'll wrap up and go through an overview of the actual toolkit. I do believe folks can unmute themselves. So if you have a question, shoot it through the chat box, or try and unmute yourself, and hopefully we can navigate it from there.
Hi, will you be sending the toolkit through email?
Yes, so the toolkit, we'll go through that in just a few minutes here, but we'll circulate the slides, this recording, the archived chat script, and then the toolkit will also be available for you to download.
Great, thank you so much. It was a great training.
Glad to hear that.
Yeah.
And so I think, sorry, I was going through the questions.
I was going to say there was a lot of Q&A throughout the duration of the training. So
Yes.
Deanna mentioned at the very beginning that folks were on fire. So before people sign off, I'm actually just going to give a quick plug for an evaluation. So I'm going to include a link to a short survey. It's our evaluation link. And so we are going to still be open for questions. Deanna, if you want to wrap up, then I can jump in. Or I can include the survey here and we can take questions as they come in.
Great. So just wanted to finish off by saying, in summary, like today, we just wanted to emphasize the role of Hep C health promotion in the navigators services. And so we have this pocket card with the 8 key messages that can be used during the outreach process and even throughout the entire process getting through treatment. And just highlighting again the steps for patient navigation, which start from outreach into testing, linkage to care, completing medical evaluation, starting and being adherent and completing treatment, and after treatment liver health. And so there is the health promotion guide that can support the transition through all those steps with information to provide questions to ask the patient, and just how to develop the care plan, the treatment plan for that person. And so we have included a lot of links here with the link to the toolkit, all the recommendations and other resources that I mentioned throughout the presentation today, and some additional resources as well. And just a final statement that specialty pharmacies help. And so if you do have one that you work with, or there's one in your region, in your neighborhood that you can work with, that is a great resource. And finally, just wanted to give you our recommended list of trainings for new patient navigators. And so today we did a very condensed version of our Hep C patient navigation training. But this is the list of essential trainings as well as recommended. And all of these are available online with the New York State AIDS Institute or at the Harm Reduction Coalition website, which is a great resource. If you don't know about them, please check them out. And that's all. So thank you, Jasmine, for putting the the training that's happening tomorrow on Hep C prior authorization tricks of the trade at 4:30 p.m. Eastern time. So there's a link to register. That's an opportunity to get more specific information about the prior authorization process.
Excellent.
And the evaluation link is in the chat. It's very simple. It only takes a few minutes to complete, and we would really value your comments. Thank you.
Deanna, all good?
All good.
All right. Well, before folks officially sign off, if we were in a room or, anywhere else, we'd applaud or snap or give praise and then hug it out. So I really just want to thank Deanna and Marie and everybody behind the scenes who helped put this together. So from a distance, I am applauding, as are a handful of folks that are chiming in through the chat box just with warm thank yous. And my one word is grateful, very useful information. So we just want to share that gratitude for the presenters taking the time today, but also to all of the attendees who are on the call for taking this chunk of time out of your day. Again, just a plug for the evaluation. We do highly value this feedback. It's for us to acknowledge our room for growth for ourselves and also how we can evaluate the support that's needed to improve our TA processes and future trainings that we do. So I want a drum roll because I'm like, maybe it's what you've all been waiting for, but we are going to dive into some of the content that we've been talking about through the duration of this training. It is our Hepatitis C Community Navigation Toolkit. So there were a handful of tools that were shown throughout the training. There was some screen sharing, there are hyperlinks within the slides just for what actually the toolkit entails. But I just want to give a quick overview for how folks can access these tools and the toolkit. So these are part of a toolkit that was launched in September. Just to provide some context, NASTAD and the New York City Health Department developed these tools with contributions from patients, navigators, and additional staff. So this toolkit consists of program protocols. It includes data collection tools. It has patient education materials that we've seen throughout this training. And they've actually all been used through New York City's Hepatitis C patient navigation programs. The feedback that we've received to date about the toolkit, because it's open to feedback all the time, because there's always room for improvement. But folks have said that it's very user-friendly, it's easily digestible, and they really appreciate the fact that it's not branded. So it's customizable to your specific context. It guides patients and peer navigators to conduct targeted outreach, provide harm reduction services. We have appointment accompaniments, medical interpretation, referrals to health insurance, and Deanna showed some screenshots of those today. But I do want to mention again, that it was just very intentional to leave the tools and templates not branded so that you all on this call can tailor them to exactly what you need. So if we click on this link at the bottom here, it takes us to what our NASTAD microsite, which is, I'm still screen sharing, right? Okay, I just want to make sure everybody can still see what I'm looking at since I transitioned websites. So this actually takes you to where the toolkit is housed. This is you can scroll down here and you can actually see the official launch of the toolkit. This is a recording that we did in September that provides a detailed overview about how the toolkit can be implemented in your specific jurisdiction and also to strengthen your hepatitis navigation program. So another warm thank you to Deanna and Nira, who are actually the presenters on this training recording here. They walk you through lessons learned from the field, best practices, how to make meaningful connections, and basically how to navigate and get individuals linked to hepatitis C cure, which is what we went through this whole training today. So up here at the top, we do have sub-tabs, and you can take a look at navigation, program design, the tools. If we click here on the tools, all of these are hyperlinked to specific PDFs. So maybe you are interested in the Hep C Health Promotion Guide that Deanna showed a screenshot of earlier. If you click here, it takes you to exactly that place in the toolkit. So granted, the toolkit does have quite a few pages. It is very lengthy. You can control find whatever you want. But if you have something in mind that you want to access, then this is where you can do exactly that. And you can go, Hep C basics, getting ready for Hep C cure. If you go back, we also have, these 1 through 6 here, where you can still you have some useful practical pocket cards that you can give to clients, available in Spanish. We have far more detailed forms, such as the handout for keeping in contact, which is useful for navigators to read through, with practical suggestions for not only relationship building, but we're minimizing that loss to follow-up that a lot of folks had mentioned as a barrier earlier on. I just want to take you through this navigation forms and templates. So I'll show you a few forms here. We have the navigator business cards to case note templates, 3 different forms of Hep C navigation forms. And again, this is the beauty of it. You can choose, which ones you're going to use for which community outreach. They're all accessible for you to check out and see what's best fit for your program. Lots of questions about, if the toolkit was going to be sent. I think the beauty of it is, I just want to show you here. If you're like, wait, I can't find that slide deck, or, what link was I supposed to click on? If you just open a new tab, you can type in nastad.org. And we've just tried to make it as easy as possible to have this banner here, easy access to the community navigation toolkit. You can click on it, and then you have, I want to say, everything that you need at your fingertips. We are always open to questions, to feedback, as mentioned. I am going to give a shout out to our Hepatitis Technical Assistance Center. This is NASTAD's HepTac. It's an online platform for health departments to request TA. There's a quick response time. To date, we've had several requests that vary between topics, timelines. We've been able to assist with all of them. So I don't want to be hesitant when I say no ask is too big, but we will definitely be able to connect you some peer-to-peer learning or support, and connect you with folks that you need to be connected with to fulfill that TA request. We also have something similar for NASTAD's drug user health team. They're providing technical assistance. It's open to all through their TA center, and it's accessible via this link here. So we have a lot of cross collaboration between teams, the hepatitis team, the drug user health team, even our HIV prevention team. But we just wanted to let folks know that community-based organizations, non-health department staff, you're able to request TA through this platform. And even aside from that, NASTAD's hepatitis team, NASTAD as a whole, we're here to help support, and you can always reach out to us at hepatitis@nastad.org. So again, some lighthearted fluffies here with a warm thank you from Pusheen and just an evaluation reminder. I do think that we still have a few minutes. I don't know if questions came through, but we can revisit that and see if we have some answers to them. Anybody have questions? Or did I miss any in the chat boxes I was presenting?
I don't think so.
All right.
Jasmine, we had one question about certification and whether or not a person can receive certification for this training.
So for this training specifically, unfortunately, it's not available. I do know that the team has had some discussions about future trainings and how we can make that available, especially for folks who are engaging for hours at a time for a chunk out of your day. So for this training, no, but please know that we are acknowledging how to do so in the future.
I think if somebody needs a certification, like a certificate of attendance, we might be able to do that, or we probably could do that, but we don't have the continuing medical education. We don't have CHEST credits or CASAC credits for this particular training. If there's interest, let us know. We will try. But if it's an attendance issue, we could certainly verify attendance.
Thank you for that clarification, Marie. Yes. I think I see Irene and Russell. If you want to reach out directly, then we can absolutely provide that. Anybody else on the call who needs that certification of attendance, definitely. All right. I know folks are still on the line. Any questions or just comments?
I just want to acknowledge a question from Jamie on implementing Hep C navigation at certain service programs. And so I want to echo what Neera has said, like if please feel free to reach out to us. We can discuss this further and provide like our experience in doing this. But as she mentioned, we have implemented this at 14 syringic service programs. And so it's a matter of making sure that the staff are coordinating with each other. We did find some silos happening, and so that was like caused the disruption in some of the services. But making sure that training is available to everyone that should be involved is important. And we also work with the harm reduction services contract manager. And so that is useful in making sure that the goals for the two service areas are met and that the teams are working together if they're not the same team.
Thank you for that, Deanna. I see Dr. Kimberly here. For the names on the certificates, we actually will have saved this chat box script. So I will be sure to follow up with folks who specifically said they want a attendance certificate. Anything from NASTAD staff on the line, or we have Neera, Deanna, and Marie, New York City?
Nothing here. Great job, everyone.
Thank you.
Here was a full day. Thank you so much, everyone, and to Deanna and Marie and Jasmine for facilitating, and the attendees were so proactive. So it was exciting to meet everyone, an enormous community of practice and learning. So hopefully we can reconnect with some of the people on the call in the future.